I think we'll get started. Thank you everyone for joining, and thank you for, I don't know where I should stand. Maybe I'll stand here. There. Thank you for the people who are joining online as well. We're really pleased to launch this new seminar series about the art of the possible for clinical AI. Everyone knows everyone's talking about it. Everyone, even your mothers, right? And AI in general. And of course, in healthcare, there's so much opportunity for it. And so we wanted to have the opportunity to think as a precinct and as a university about, what are the possibilities for clinical AI? Because there are so many. And not just what are the possibilities, but then how do you really make it happen? That's what we're interested in here in the Center for Digital Transformation of Health. It's really that application of new technology and of data analysis to clinical care and help. So we are really pleased to introduce the first speaker of this series, Dr. Shyam Visweswaran. And Shyam is a professor of biomedical informatics at the University of Pittsburgh. He and I knew each other when I was at Pittsburgh for 10 years, and he was a student there when I first got there in the Intelligent Systems program. And that is a program that was started in the early 2000s by Bruce Buchanan, who was my postdoc advisor. He's kind of a grandfather of AI. And came from Stanford, went to Pittsburgh to start this program, an Intelligent Systems program, which is a program in AI. So that's been around for a long time. It's a PhD program that trains a lot of great students in really rigorous AI applications, and it has a health track. So Shyam is now also the vice chair of the Department of Biomedical Informatics at University of Pittsburgh in research, clinical research. And he's also a wonderful person. So looking forward to him describing the journey he's been on as a clinician, as an AI researcher, and as somebody trying to build infrastructure to enable and support the application of AI to clinical care. So thank you, Shyam.
Yeah. Okay. Okay. Can you see my first slide?
Yes, that looks good.
Okay. That looks okay. Yeah. So yeah, it's really great to be sort of the first inaugural speaker for the seminar series. We actually have a seminar series which is focused on machine learning for clinical applications, which has been on for about almost 3.5 years, which started during COVID. And I'll put the link to that later on. We pretty much record all these presentations. It's a virtual series and put it up on the web, and it's been running on Zoom for a while. So what I'll do is I will talk for maybe about 45 minutes, leave some time for questions and discussion, and talk about some of the work that we're doing here in Pittsburgh for AI-based clinical decision support. So broadly speaking, the application of AI in medicine can be split into sort of two big buckets. The bigger bucket is really for biomedical discovery. So this is where AI is used a lot, where you're applying AI to big data and then multimodal data, combination of data coming out of research with data coming out of non-research areas like electronic health records, for example. And bulk of the research and bulk of the literature that you see is usually focused on this, coming up with new discoveries in biomedicine. There's a smaller bucket, which is what I'll talk about today, which is for clinical decision support. And clinical decision support is defined as providing clinicians, patients, or public health officials with knowledge and person-specific information. And it's done in an intelligent way. And more and more AI is going to make inroads into decision support at the point of care to make clinical decision-making more effective. And so basically, let me see. Okay, let me first give you an outline and then I'll go back to the previous slide. So I'm just going to talk a little bit about why do we need AI? This is a question I'm often asked by medical students and junior physicians because there is a fear that AI is just going to take over all of medicine. And the question is, where does it actually fit? And when do we need it? Then I'll talk a little bit about evaluation of clinical decision support that uses AI. Give you a few example projects that we're doing here, and then I'll touch briefly on one of the areas that we really need to worry about is algorithmic bias when we use AI, and I'll just touch briefly on specifically on race as a problematic space for these kind of AI applications. So one of the things that's happening in the US is that the FDA is just approving a whole lot of AI-based decision support. And so these are, FDA calls them AI-enabled medical devices, but bulk of this is really AI software, which is running maybe say for clinical images or in the electronic health record systems and producing some kind of output. And as you can see, it's just going up tremendously at this point. So I'll sort of make the case for why we need AI in clinical decision support, because we have at least 3 clinical challenges. The first one is knowledge overload. And it's due to the fact that medical knowledge is exploding and it threatens to overwhelm human memory capacity. And this is especially true with all the molecular discoveries that are coming around. And the whole premise of precision medicine is basically trying to pinpoint the particular disease in terms of molecular mechanisms. And this is problematic for humans because most of us, when we went to medical school, and even today, if you go into medical school, the way information is organized is really not based on molecular basis. It's kind of organized in a clinical pathological basis or histological classification. So for example, breast cancer, the way I learned it in med school is sort of classified this way, and you don't see anything which is molecular out here. And it's kind of based on what you see under the microscope. And these kind of classifications around which medical knowledge is organized doesn't change that rapidly. So you could learn this stuff in med school and probably can apply this for the next 20, 30 years without much changing. But what's happened now is that we have this molecular classification. So here's an example for breast cancer, and this keeps changing pretty frequently as time passes. And as you can see, you have these, even this, the way information is organized, there's no way we can keep this in our heads as humans. So you got all this acronyms and numbers and so on and so forth. And so you really need some computational support to be able to even keep up with the knowledge and organize and keep it organized the way it's currently being organized, which is from the molecular aspect. The second challenge we have is data overload. So the amount of clinical data that is being generated per patient has also gone up tremendously. And it's come to a point where it's probably starting to overwhelm human cognitive ability to process such data, especially in places like, say, the emergency department or the intensive care unit, where there's a large amount of data which is generated for each patient. And this is this number that 1,400 new data points are generated per patient per day in critical care is pretty old. This is more than 10 years old, and it's probably closer to 2,500 new data points today in critical care. And so there are limits to human cognitive capacity. And basically, as this slide shows, in the past, the amount of data that is coming through and the amount of data you have to consider as a provider or as a physician was limited to what you elicited by history and physical examination and, say, lab tests and some imaging results. And you could handle this by looking at the raw data. But as more and more molecular data starts to flow in, that's going to become pretty intractable. You can't even look at, say, raw genomic data, for example, and that's the genome gets sequenced for every patient, and that ends up in the electronic health record. There's no way you can look at that raw data and actually parse the information, and we're going to need computational help to make sense out of that data. And then finally, there is process overload. This is currently sort of, I would say, particularly problematic in the United States because there is so much time being spent by physicians to both review results and to enter information in the electronic health record. And there are studies which show that primary care physicians, for example, can spend up to 6 hours in an 11-hour day just documenting information about patients in the EHR system. And the retrieval of this information is also problematic because most of the EHR systems which are currently in place don't really have good ways of retrieving information or doing it in an intelligent way for clinical purposes. And this is just a study showing that even among clinical notes in the US, you tend to produce tremendously long clinical notes compared to, say, in Europe. So these dark green bars are basically what you see on the x-axis is the number of characters in a note, and what you see on the y-axis are institutions. And so these dark green bars are basically European institutions, and you see that their notes tend to have fewer characters in this ambulatory note, while in the US, which is all these light green bars from various institutions, they tend to be much, much longer. And for most part, these long notes really don't have that much clinical utility over what the European notes have. Part of the problem in the US is there's a lot of documentation which happens not for clinical care, but for reimbursement purposes. And that's what you see in these notes. And studies are now showing that just documenting these long notes and trying to retrieve them at the point of care is probably one of the causes of burnout among physicians. So those are sort of three reasons why we need computational help for physicians at the point of care. So next, I'll sort of get into this evaluation of clinical decision support systems that use AI. And so in the US, this is something that the National Institutes of Health has come up with for biologics. So suppose a new biologic, like a new vaccine, has to be introduced. Usually, it goes through these various phases, which is called T0 to T4. T0 refers to basic research. These are preclinical, in vitro, and animal studies. T1 is translation to humans, where these are phase 1 studies which are done, where the biologic is studied in a small number of healthy people to primarily assess safety. And then once it's shown that it's safe, then you move on to T2, where you study the biologic in a slightly larger population. And this time you're assessing efficacy of the biologic. And once it passes through T1 and T2, then you have these large-scale clinical trials, which are done to both verify safety and efficacy. And these are the kind of studies which are then, the results are provided to the FDA in the US for approval. And after that gets done, even after the biologic is introduced into clinical practice, usually there's post-deployment monitoring and studies which are done to monitor their safety and efficacy. But unfortunately, the clinical decision support systems which use AI don't really go through these phases. And in fact, the bulk of what has been approved by the FDA, there's almost no literature which is out there, which tells us anything about safety or efficacy or efficiency of these decision support tools. And it seems that we need to have sort of a similar pathway for assessing decision support tools before they are introduced into clinical care. And pretty much we can make the case that something along this T0 to T4 pathway can be applied to clinical decision support too. So you can think of T0 as preclinical creation of AI models and development of the tool, which will eventually go into the electronic health record system. T1 would be where it is studied retrospectively in a lab setting to assess safety. And then T2 would be where it's studied in the field, maybe in a hospital or a clinic to assess performance. And then for most of these tools, especially the ones which are used in critical decision making, you probably want to do a randomized trial, like an RCT in biologics, equivalent of that, to verify both safety and performance, and then have it approved by the FDA. Currently, it's not clear what kind of data FDA gets to approve all the software that they're approving for AI CDS. And post-deployment monitoring also is very critical for these, because these models can undergo drift. They can change their performance quite rapidly, and they might be biased for new populations on which the model was never developed. So they have to be continuously monitored even after they are introduced. And currently, as I said, in the US, most of these things which are being introduced really don't go through this rigorous steps. In Europe, it's probably a little bit better because there's safeguards being put around AI in any field. And so they're a little bit ahead compared to the US. So just with that sort of background, I'll get into, give you some examples of projects that we're doing. Most of these are still in the research phase. And I'm going to split them up into sort of based on this response time, because the engineering aspects change quite a bit based on how quickly the system needs to respond. So you might have a system which is doing some kind of monitoring, and that would have to respond in seconds. You might have systems which are running, say, in the intensive care unit, which might have to respond in minutes. And then systems which are used, say, in the outpatient clinic, those can respond. They don't have to respond immediately, and it can take even a few days for the system to sort of compute whatever it needs to compute and provide that information. And so I'll go through like 3 examples of this. So the one system that I'll talk about, which responds in seconds and probably even in sub-seconds, is a system we are building for monitoring intraoperative cerebral ischemia. There's also a second system, which is looking at predicting post-induction hypotension in anesthesia, but I won't talk about that. The second one I'll talk about is identifying relevant patient data in the ICU using a machine learning approach. And there's a similar project which is trying to do anomaly detection in decision-making of clinicians in the ICU. That's basically, it's a very long-standing project, which one of my colleagues here, Miloš Hauckratz in computer science, has been working on this for more than a decade. And then I will talk about a little bit about an outpatient system, which is being put in place to predict opioid dependence in the outpatient clinic. And there's a second system which is being developed for predicting risk of bleeding on direct anticoagulants. So direct anticoagulants are a new class of anticoagulant agents, which are different from warfarin. Though they have less bleeding risk, they still have bleeding risk, but there are no prediction models at this point for them. So, so monitoring intraoperative cerebral ischemia using EEG. So in certain high-risk surgical procedures where there's worry that the blood flow to the brain might be compromised, the current state of the art is to continuously monitor during the procedure using EEG in many places, the EEG monitoring is done by a different personnel and not by the anesthesiologist. And so here at Pittsburgh, it's done by neurologists who are specialized into this. So what you have is typically a technician who is in the operating room, and his job is just to monitor this EEG in real time. And what basically this person is doing is they're looking at this 8 squiggly lines constantly and trying to figure out whether the blood flow is being compromised or not. And then since we don't have that many physicians who are specialized into this, there's typically a physician who is sitting somewhere else and is simultaneously monitoring up to 8 procedures, and the data gets fed to the physician. So you have a technician in operation and a physician who is overseeing multiple procedures simultaneously. And the problem with this kind of monitoring is that humans are not very good with this kind of monitoring. People get tired. And it's actually been pretty well established that after the first 3 hours, things get missed with this kind of monitoring. And so our goal is basically we are building standard machine learning models which are doing sort of supervised learning, which will output a prediction probability of ischemia continuously several times a second. And this can be used for basically alerting whoever is doing the monitoring. So there's a human in the loop system. So you don't get rid of the technologist in the operating room, but you just provide an alerting system. And what this is showing is it's pretty clear cut that these red squiggly lines, so red basically means it's the right side of the brain, and the blue means it's the left side of the brain, which is being from where the signals are being collected. And you can see that on the left side, the blue squiggly lines, there's one where the amplitude is pretty low. And then in the red side, all of them, the amplitude is low. So that's typically what happens when the blood flow gets compromised. And this is coming from carotid endarterectomy, which is a procedure where they're operating on the carotid artery in the neck, and part of the procedure involves clamping the carotid artery. And usually what happens in this procedure is the surgeon will clamp and wait to see whether the blood flow is compromised enough that they have to release the clamp and shunt, versus whether they can just proceed because the other side, the other carotid will take over. So typically this happens, and then they'll wait for a minute or so and hope that these amplitudes come back. If it doesn't come back, then they basically have to release the clamp and do something else. So that's one example of a procedure where the EEG has to be done in every patient, and that's the standard of care. More and more, it's done for practically every brain surgery, as well as for most of the heart surgeries. So almost all open heart surgeries out here are now monitored with the EEG, because when they're operating in the heart, often blood flow to the brain can get compromised. So this is basically how the data gets annotated. We have somebody who looks at this EEG data and tells us what are the periods where it's normal, what are the periods where there is ischemia, and then you do standard machine learning, which is split the data up into training set, test set, and build models and assess their performance. And we just applied classical machine learning models like random forest and like GBM and extreme gradient boosting. And so far, we've sort of reached area under the ROC curve of 0.8 and sensitivities of like 50% and specificities of 90%. What is interesting about this problem is that depending on the procedure, you have to readjust the model to work at a certain sensitivity and specificity. So for carotids, for example, they want it to be highly sensitive. So you really have to operate the model at a very high sensitivity. And so you have to adjust the threshold so that it's highly sensitive. But if they are doing open heart surgery, then they prefer high specificity. So these results we have here was sort of fitted for open heart surgery, and so the specificity is high. And this one actually shows in real time that you can see that the probability is changing. And as you can see from this EEG, it's actually hard to make out that indeed that the amplitudes are falling gradually. And the model is able to pick this up. And the experts can pick this up and they say, yes, that it is starting, it's getting worse and worse. from left to right. But for us, when I look at it, I think it looks roughly the same from left to right. So it does help having this AI working and running and producing this probability. So the engineering part of this is you have to basically embed the model in the computer system, which is acquiring the signals in the operating room, because it will be really, really close to be able to acquire the signals and apply the model to the signals. And we, at this point, are applying the model every second, and that's probably insufficient. We probably have to apply the model maybe around 10 times every second. So you have to process the incoming signal, apply the model quickly, and then output the probability. And so pretty much the entire code base, which was used to do the model development, has to be rewritten at this point to actually make it work in real time. And so currently we're working on that so that we can apply these models in the computer system, which is sitting in the operating room. Okay, so now I'll shift to this next example, which is where we're looking at things where we want to do in times of, where the time duration is more in hours rather than in seconds. And this is a project that is pretty old called the Learning EMR System. And the basic idea here is that we have the problem, especially in the ICU, that so much data is flowing through the system that sometimes when clinicians come and log in, say in the morning for the start of the shift, they might actually miss some information which has come in over the past 8 or 12 hours. And the idea of this is, can you use machine learning to just highlight some important information which is sensitive to the context of the patient? And it's not easy, because if you do something simplistic like just highlight all the lab values which are out of range, typically in an ICU, everything is out of range. All labs are out of range. And most of the time, clinically, we don't care about every lab which is out of range. You care more about how the labs have changed. And so the system has to pick up that and not just very naively just highlight anything which is out of range. So that's pretty much what the goal of building sort of machine learning for this project. So this is an example of something that was built in Mayo a long time back. And it's a very nice way of showing information in a very compact way to ICU physicians. So the way critical care physicians work is they basically work their way through about 8 to 10 physiological systems. So they'll start with, say, the nervous system, the cardiovascular system, the hematological system, and so on and so forth. And then they look at each system, look at all the data in that system, figure out what needs to be done, and then move on. So this particular figure is basically showing the cardiovascular system, and it's all the relevant information to the cardiovascular system is shown here, including the medications, as well as the physiological parameters. And things which are highlighted is what the system thinks are sort of important for the physician to know. This is based on rule-based system. So there are rules running at the back which look at the data and decide to highlight information which is thought to be important. The alternative is to use a data-driven approach, which is what my lab did. And the idea here is that we want to be able to learn what is it that is most useful to the physician in the context of the patient's clinical condition. And so the way we set this up is we basically had physicians look at past cases, and we asked them to basically tell us, based on what they know about this patient, what do they think are the important pieces of data? And then we use that to do the model learning. So idea basically is to collect these patient data access patterns, which is a lot of effort and time, because you have to get physicians, critical care physicians, to tell us that. And then after that, it's simple. You just do training with machine learning, and then you can apply it to to new patients to predict data that the physician wants to view. So this was the interface that we built for the project. And the idea was that we wanted to summarize pretty much all the information for a critical care patient in one screen. And the way we set this up was based on the feedback we got from the critical care physicians that they wanted the information to be categorized into categories. So we had the vital signs, and if they're on ventilators, the ventilator settings on the left-hand side, and then the intake and output, which is basically fluids and food going into the patient, and outputs which are coming out like urinary output, that has got its own little place. And then the medications, which are grouped by route. So typically they want medications, terms of the medications which are given by IV, medications which are given orally, so on and so forth, and they get grouped that way. And the bulk of the data is lab tests, because labs get done a lot in the critical care, and these also get grouped because physicians consume information in chunks like basic chemistry and other chemistry, fluid chemistry, so on and so forth. And then the last panel was basically all the clinical reports, which we actually didn't use for the machine learning, but you had to provide this to actually elicit labels from the physicians. And then the idea was that when the model has been built and then it gets applied to a new patient, then it would essentially highlight, as it is shown here with this orange borders, basically drawing the attention of the physician and saying, okay, these are important things that you should look at. So the machine learning part of this is you basically take all the data that is available in the electronic health record, which are structured data. When we did this project, we didn't include the text data. So things like demographics, lab tests, medications, vital signs, procedures, all of that stuff is included. And then we have physicians painstakingly telling us which of these data elements for that particular patient they think is important for their decision making. And so now you get these labels, and then you can build models. And then we ended up building basically models for trying to predict every data element which is there. So we ended up building about more than 1,000 models. Most of the models were not that great because our sample size was pretty small, because we had to use physicians to give us these labels. But these are like some of the models where you can see that it's sort of decent performance, like random forest performing at 94% area under the curve, to be able to predict whether red blood cells in a particular patient, when you see that lab test come up, whether you should pay attention to it or not. And so this was sort of a prototype, and it was well received by the physicians. The problem was that we had only enough data to build models for about 100 plus elements, so that we could reliably predict those. Ideally, we need to predict everything. And so the way we acquired the training data is obviously not scalable. And so the future version of this project, the idea is to use something like eye tracking, which would run in the critical care as physicians are looking at data, and then capture through eye tracking what is it that they're looking at, and sort of get labels that way. And we have done some preliminary work to show that if you build models using labels derived from eye tracking, they're almost as good as labels which are derived from physicians manually telling us what's important. So, and then the engineering part of this would be, like here we have the Cerner system, which is in the ICU, and we would draw data from the Cerner system, maybe like every 10 or 15 minutes, or maybe even up to every minute, and then process the data, apply the model, and send the output back. But in this particular case, you can actually wait till actually some data flows in. You really don't have to do anything for a patient unless some new data flows in. And when the new data flows in, then you can pre-process, apply the model, and predict whether that piece of data is important or not, flag it, and then when the physician logs in, you would have all these flagged data elements for them to look at. So here, the engineering process is a little bit different. We can extract the data and do all the modeling application at a remote place, which would be, say, on the university side. We don't really have to be inside the hospital system to apply these models. We can apply them outside and push the results back into the EHR system. Compared to the previous one, we really have to be inside the hospital system in that monitoring system to be able to consume the data quickly and apply the models. Here, you have a little bit more leeway. So then finally, I'll talk about this thing called MPRO1. The goal here is basically to predict who would be at high risk of becoming opioid dependent. And this is especially for patients who need to be on long-term opioids for various reasons. And if we can predict reliably who will become dependent, then the physicians could put them on alternative medications. And if we predict that someone is not going to become dependent, then it's okay to leave them on opioids because opioids are really good for certain conditions. And so this here, my group really didn't do the modeling part. The modeling was already done by a different PI, Walid. The models have been developed using EHR data, and it's an XGBoost model. It has been actually evaluated both here at Pittsburgh and an alternative site in Florida, showing that these models are relatively good. And now we are actually going to move it to a clinical trial where my group is implementing this model for Epic, because Epic system is what we use in the outpatient. And I'll show you how this one is engineered. So one of the things that we do in our department, and I'm deeply involved in this, is that we have built a clinical research data warehouse where we pull data from all the clinical systems and harmonize them and make it usable for research. And when this warehouse was initially built, it was basically built for retrospective research, where people want retrospective data sets for various kinds of analysis. And so the system used to be behind by about 2 to 3 weeks in terms of getting the data from the clinical systems. But to do decision support, you have to get it more frequently. But we are not in a position to pull data like on a minute-by-minute basis from the clinical systems for the entire hospital system, because it's a pretty big hospital system with 42 hospitals across the state here. And so what we have done is we have picked a project where we have to process, we only process the data once a week. So we pull the data in, apply the models for the patients who are going to be coming to the clinic in the coming week, and apply the models only for them, and then compute it, say, on the weekend, and then push the probabilities over to the clinical system. So this is the original data warehouse, which was built for retrospective data. So UPMC is on the clinical side. Part of the warehouse sits on the clinical side because the university side is not supposed to see personally identifying information like name and medical record numbers. So as the data moves over to the university side, the Pitt side, the data gets de-identified. But we have to maintain all the identifiers somewhere, because that's the only way to update the data as new data arrives. So this is a warehouse which actually has got footprint on both the clinical side as well as on the research side. And so we have now extended this warehouse with this green module, which is where the decision support machine sits now, which is on the university side. And what this is now starting to do is to pull data weekly for this particular project, apply the models, and then push it back to the clinical side where it gets matched up with the medical record numbers. So essentially all the processing and all the data which happens on the university side, it's all de-identified. And then when it gets pushed back to the clinical side, the medical record numbers are reattached, and then it can go back to the clinical systems. So we are pretty much close to having this whole pipeline set up, and the study itself will start later in the summer. So I kind of gave you 3 examples where the engineering of the decision support is very, very different. And so some of the takeaways is that one, especially if you're working with people who are doing model development and you're going to implement the decision support on their behalf, there's a lot of education to be done, because model developers often assume that whatever code that they have just needs to be tweaked a little bit and can be translated into a decision support. But setting up decision support is a very different task compared to model development, and the code has to be pretty much built from scratch. And so all the pre-processing and handling missing values, everything has to be redone for decision support. And one of the biggest issues is that during model development, since it's offline, a lot of it is done manually. So you develop a model, and let's say you want to handle the missing data somewhat differently, or the data is missing and the code stops working, you just go in and manually fix it and get it up and running. But on the engineering side, when you're doing decision support, you can't be doing that. You have to handle all possible scenarios so that the model doesn't break. And so on the implementation side, what we are discovering is you really have to understand the entire model development process and take all that information and re-implement it in a different code base. So you have to basically develop new software for pre-processing, model application, output verification. And the implementation and the engineering characteristics of how you process the data really differs on how quickly you have to respond, whether it's seconds, minutes, or days. If you're trying to respond in seconds, you really have to get down to figuring out how can you process that data in seconds. So if you're taking every second worth of, say, EEG data coming in, you have to have this machine be able to pre-process the data, apply the model, and spit the probability out. And sometimes that gets into optimization at a very low level. However, if it's like in days, like in the opioid one, then you have a lot more leeway, because you can run the essentially things in near real time and sort of not have to do it at the point that the patient is actually seeing the clinician. You just pre-compute everything and keep it for the next week, and then push the results out as they're needed. And at least here, what we are discovering is that ideally we want to have bulk of the AI CDS software implemented outside the vendor electronic health record systems, especially during the research stage. One, because inside these big vendor systems like Epic and Cerner, you may not be able to implement big AI models, things like XGBoost, for example. You can implement things like logistic regression, but typically not these big AI models. And two, you don't have enough flexibility to do all the diagnostics that you would want. And so you want to sort of do this outside the EHR system. And so, so you have this process by which you have to draw the data from the clinical systems, process them, apply these models, and then push the result back in. Okay, so now I'm just going to shift over to this other topic of algorithmic bias due to race. And so here's an example which was published in Science in 2019, which looked into a proprietary algorithm, a commercial algorithm, which was used on about 200 million patients per year in the US to predict a health risk score. So the idea here was that this would predict a risk score in terms of how sick this person is going to get over the next year. And this would enable clinicians to maybe proactively do things that they need to do for this high, if someone has got a high health risk score. But what was discovered by the people who wrote the science paper was that this algorithm underrated the severity of the Black patients' conditions relative to the white counterparts. and it led to under-provisioning of healthcare to the Black patients. And the problem turned out that the target which was used to develop this model was not really the health status, but a proxy, which was healthcare cost. And so they were basically predicting, this model was basically predicting what the healthcare cost would be for the next 1 year for a patient. And the confounding factors would be is if you have a patient who has poor healthcare access, then this will basically predict that they don't require that much health interventions in the future. And that was the problem. And so the algorithm was taken out and then it was rebuilt to actually predict the actual thing you care about, which is the health status, and not use healthcare cost as a proxy. Another one, which is much simpler, is this clinical calculator, which is the estimated glomerular filtration rate, which uses essentially serum creatinine, age, female sex, and Black race. So this is what is used in most of the calculators which are embedded in the clinical systems. And when you use this calculator, what it basically shows is that it basically shows that if you are a Black person, then you have 16% better eGFR. So essentially, Black people are predicted to be of better kidney health than equivalent white people. And so this means it leads to Black patients waiting longer before they get diagnosed with kidney disease and getting sicker before they get, say, kidney transplants. And so the current goal is now to take race out of this equation and rebuild it. And in fact, some of the health systems have already implemented an equation which doesn't have race in it anymore. So one of the things that my lab did was we sort of looked at all the clinical calculators out there and pulled up the ones which have race in this. And so we have this online database which lists these. There are 38 risk calculators which have race in them. There are 6 laboratory tests where the reference ranges change based on race. And then there is at least one therapy recommendation which is based on race. Since then, we also discovered that there are at least 15 medications where the FDA guidance uses race as something that clinicians are supposed to take into account for prescribing that drug. And more recently, we have discovered about 6 medical devices like pulse oximetry, which perform differentially across the races. So one of the things that we are trying to figure out, and we are using this particular calculator called UTI Calc because that was developed here in Pittsburgh, is to figure out, number one, does a calculator which has race in it, is it necessarily inequitable across the races? And 2, if it is inequitable, can you fix it in some way? And so we have a really nice sort of use case out here. This urinary tract infection calculator is basically used here in the Children's Hospital. It was developed here, and it's actually used widely across the US now. And the idea here is that young children who are 2 years of age and younger, who are not potty trained, when they come into the clinic or into the emergency department and the clinician suspects that they have a urinary tract infection, the standard of care that you're supposed to do is basically catheterize the bladder, get a clean sample of urine, send it out for culture, and then based on the culture, prescribe the appropriate antibiotics. But the problem with that is it's painful to get the sample, and often anyway, antibiotics are prescribed before you get the results of the culture back. And so what this model was set up to do was predict who is at high risk of urinary tract infection, and then only catheterize those kids. And if you're at low risk of infection, then you just treat them with antibiotics, but not send their urine samples for culture. And the initial one included race in this logistic regression model. And there was a subsequent one which was built, which excluded race because the American Academy of Pediatrics basically said nobody can use calculators which have got race as a variable in it. And so in this slide, this V1 column is the version 1 of the model which the clinicians built, which has got race in it. V3 is the new version of the model that they built where they took race out. And my lab, what we did was we played around with the data that they have. So we built logistic regression models, which has all the features that the data set has. It's got only really 11 features. And there's also software which is available where you can optimize a particular performance metric across the two races. So for example, in this particular algorithm, this is supposed to be a screening algorithm. So you want it to have really high sensitivity. So the clinicians wanted 95% sensitivity. And so version 1 of the algorithm, the difference in the sensitivity between the black and the white kids was 8%. And so basically the white kids, it was about 96% sensitivity. The black kids was around 89. But when you sort of did the weighted average, you got 95%. And it improved quite a bit when they built the V3 version of the algorithm. But we were basically able to calculate this. And in the fairness world, they call this EOP. But what this is really the difference in sensitivity between the two groups. But what is interesting is that if you look at all kinds of other metrics like specificity and positive predictive value and so on and so forth, the best equation or the best logistic regression model is the one which contains all features, including race. And so we took this back to the clinician and basically asked them what they would like to do, whether they would want to put in a model which has got all the features, including race, or keep using the V3 of the algorithm. And their current thinking is they're just going to stick to their V3 and not use the one that we built. But this basically brings up the whole question of, yes, this model was inequitable across the races, and it was partially fixed by taking race out. But it turns out the model which has got race in it is probably the better model in terms of performance. And people don't want it because, you got this blanket recommendation from the American Academy of Pediatrics that you shouldn't use race. So there's an interesting discussion going on as to how do you handle even race as a variable in these clinical calculators. So I think with that, I'll wrap up. And these are all my collaborators, and this is all the funding which has supported all these various projects. And I'm happy to take questions and comments.
Thank you so much, Shyam. So we have about 5 minutes left, and I thought I'd start with people online for questions, and then we have a lot of people in the room. Really happy to have you here, and we have refreshments afterwards, and so we could go a little bit longer to ask some questions and cut into our refreshment time. So I don't have access to someone. Eileen, do you have the questions that are listed online? Thank you. Okay, so it looks like Lyndon, would you like to ask your question out loud or have me read it? Oh, you're up there. Yes, please do.
Yeah, happy to ask out loud. Great talk, thanks, Shrikant. I was just wondering what your thoughts on the sort of deep learning neural net-based models and where they might fit in sort of now and in the future, strengths, weaknesses versus the traditional models that you were presenting today.
Sure. We are actually using deep learning methods for the EEG project at this point to improve its performance. And I would say in many situations, deep learning is definitely better. The only situation where the traditional machine learning is probably the best are tabular data. So when you have tabular data, there's been a fair amount of studies which now show that ensemble methods like random forest, XGBoost seem to perform the best. And deep learning doesn't offer you any additional advantage. But when you're looking at image data, when you're looking at biosignal data, the deep learning methods perform much, much better than the traditional methods. So yeah, other than tabular data, the moment you start adding all other kinds of data, you should use deep learning as one of the methods when you're evaluating and building these models.
Thanks for that question. Can I follow up on it? What does that mean for implementation? If you have a model that uses deep learning, does it change anything in the implementation?
As long as you have a server that you control, the implementation is not such a big deal. Most of the deep learning methods, the inference is very fast anyway. And so you can do things pretty fast. Even things like large language models, the implementation phase is quite fast. So application time, deep learning is not, there are no problems in actually being able to apply deep learning.
How about in terms of governance? Because when you say, oh, then the university should be the one housing that algorithm, the ears in this room prick up.
Yeah.
Well, I think this is for the research side. I think when you're developing it and you're evaluating it and running studies, often when you're doing the research and doing studies, you might have to fiddle around with the algorithm. You might want more diagnostics as the study goes on. So there you want to have almost full control over the server that the model is running on. And so at least in our place, the way we are set up is the health system is completely separated. There's like a glass wall between that and the university system. Now, there are other places in the US where they're very integrated. So like Cleveland Clinic, the academic side and the hospital side are deeply integrated, and they don't mind that if you were to do a research project inside the hospital environment. But here, I guess because it's such a huge medical system, the hospital IT just doesn't want any research to be done in the clinical systems. And so that's why we are set up in such a way that almost all the research is now being done on the university side and outside the hospital firewalls.
And when you go to implement that, will the algorithms now move to a server on the hospital side?
The EEG one has to move on the hospital side. And in fact, it's getting implemented and evaluated in the hospital side. And there it's not been much of a problem because it's essentially the EEG system is its own system. It's not integrated with Epic and Cerner. And the person in charge of this is the clinical head of that unit. And so you really don't have to go up all the way up the hospital chain to ask permissions. And so that is easily dealt with. But when you're dealing with Epic and Cerner, you have to get the permission of hospital IT. And for them, this is low priority because they've got so many other things to do on the operational side. And one of the interesting questions which has come up is, if you were to make these things commercial, what is an appropriate way to deploy them? Do you make modules and send it over to every hospital which buys the system so that they can implement it locally? Or do you do it where the data flows out and you maintain your model on a different server and then just push the results in? So assuming you don't have this very short response time, you can do that. And that kind of tracks with what a lot of the software companies are doing. So yeah, like Microsoft Office, for example, used to be a piece of software that everyone bought and installed on their computers locally. But now it's all being moved to the cloud, where the software is kept on the cloud and you just access its functionality. And the advantage of doing it that way is the software can be updated minute by minute without having to distribute that software out. So running decision support models outside these clinical systems and even outside the hospital, you have the advantage of, if you find some bugs or some performance problems in the models, you can update it immediately and everyone receives the output of the updated model versus distributing this model out to everyone who has installed it. And in fact, some of the commercial algorithms which work on, like, say, CT scans, for example, which the FDA has approved, work that way. The data actually flows out to the company server, the model gets applied, and then the information flows back in.
All right, thanks. Questions in the room? Yes, in the back.
So as far as intellectual property rights go, is there any difference depending on whether the research is done in conjunction with the hospital but externally or internally?
Yeah, so maybe I'll broaden that question. It's about intellectual property, and in a broader way, it's about collaboration. So what's the role for industry, universities, and the healthcare system in collaborating, and is intellectual property an issue?
I think collaborations are going to be a necessity between the industry and academic centers, mainly because the development of the models often requires data, especially outcome data, which has to be carefully curated. And so, like even in this EEG data, someone has to label this. And there are only a few experts in this space, and they all are sitting in academic medical centers. And you need them to be able to label this data. And so we have to, in the academic institutions, do the modeling. And eventually, once it's been developed and it works, then you can transfer it out to the commercial space. And that seems to be happening quite a bit in the US. Even our EEG project eventually is going to be spun out as a startup. And once it's spun out as a startup, the academic team is not going to be the one doing all the implementation and doing all the business. It's going to be probably a CEO who is different from the academic team who's going to take over that part. And in terms of IP, basically anything which is developed in the university setting, most of the IP belongs to the university. That's the way the regulations are set up. And most places like the University of Pittsburgh, Carnegie Mellon, Stanford, they are happy to transfer that IP to a commercial entity for not that big sums of money. And so once you move this decision support over to a commercial entity, they will just negotiate with the university and get the IP, and then the IP moves over to the commercial entity. The other way the collaborations happen is I'm at this point consulting with a Bay Area startup where essentially they are producing, they're building the whole thing. They're basically using large language models for the information retrieval problem from EMRs, the ability to retrieve very precise information from the EMR by asking the system rather than trying to go through everything manually. And so they're building a large language model-based tool for that. And there, I'm an academician, but I just act as a consultant for them, and they are building everything. So there, all the IP just resides with them anyway.
Okay, thanks. One last question here. Yeah.
I just found it interesting talking about clinical decision support and the idea of coming in not inside the main clinical systems where clinicians are working. How have you found where it's not sort of inbuilt back into the main clinical systems or EMRs? Like, how do clinicians find it, like having to go to a separate system for clinical decision support?
Could you hear that, Shyam?
I heard only part of it.
Okay, I'll just summarize it as how often when you build these separate systems, how often do clinicians have to go to a different system to use the clinical decision support versus it being integrated with the EMR? And how important is that integration for the clinicians?
Yeah, I think it's very important for clinicians that they only deal with one system. We see that here because we have two EMR systems here. We have Cerner in the outpatient and Epic in the Cerner in the inpatient, Epic systems in the outpatient. And we have this very complicated data flow where some of the inpatient summaries have to be sent over to the Epic system so that when the clinician in the clinic wants to know what happened in the inpatient, they can see it in the Epic system. Otherwise, they would have to log into the Cerner system. So even just having two EMRs was such a big burden that the health system is now moving to a single system. They're going to take Cerner out and put Epic all across the system because physicians find it so cumbersome to log into two systems simultaneously and go back and forth. So with decision support, it's pretty much critical that the information that the decision support produces has to get integrated into the clinical system that the physician uses. The results of the decision support can be produced elsewhere, but eventually it has to be put into the clinical system. And that's why with the opioid project, even though all the model application happens outside and data gets pulled and all of that happens, eventually what the clinician sees will be in their Epic system, and it'll just pop up in the Epic system as part of the Epic interface, the score, the opioid risk score. So I think it's very critical that it has to be integrated with the clinical system that physicians use.
Thanks. So maybe I'll just end with, you're here in the Validitron Sim Lab, and this simulation lab has rooms. It has a hospital room there, a GP office here, and a patient home over here. And one of the main purposes is to figure out the workflows and the ways to integrate the data into the EMR on the technical side as well. So you've got the digital side where you're integrating it, and then the workflow, so that you can do these simulations and work on the back end. And groups across the world are using Smart on Fire, which was developed here, by the way, by Graham Grieve in Melbourne, and it's used all around the world. And that's the way this information is exchanged across, so that you can integrate things into the EMR, even though they're not natively part of it. So yeah, well, thank you, Shyam. It was a great talk. I think everyone can see what a good, clear thinker Shyam is. He's been working in this space for a long time and can see, the broad implications of the infrastructure needed, the ways to really develop the algorithms and determine whether they're working correctly, and the implementation side about what it means to really put it into practice. So let's give Shyam a...
Thank you.
Thank you, Shyam. I wish you could join us for